phone on mute here. Okay. So, we've been at this now since March, and I thought we'd talk a little bit about what's new. And if we go to the next slide, given all of the events in the state and dignitaries, Dr. Birx was here, I think I would be remiss if I didn't address the state alert system. And then I think the most new thing are really the understanding what's being called in some circles as long COVID, that they're going to be sort of long-term sequelae. We don't know how they're going to turn out. I thought that I would really talk about two of them, neurologic and cardiac. And so those are the most new things that I thought had come up. And if we go to the next slide, as you know, there are many alert systems if you go on the web. There are, there's the Harvard Global Health System, but there are many, many others. And I think the state, really wanted to have a handle on, sort of specific outbreaks. So we don't really have to close down the whole state or take children out of school in the whole state. And so they really put this on the web, and the governor, as you know, talked about this yesterday, that really has an alert system based on a 7-day rolling average of cases per 100,000 population. So what that is that, the state has all the cases reported to them. They take those over 7 days and average them. And then they standardize it per 100,000 population. And you can see there the definitions that are on the web. Green is 3 or fewer cases per 100,000. Up to 10 is yellow, which means community spread. 10 or above up to just below 25 is orange, where you're really sort of getting more of an accelerated spread. And then 25 cases or over is really considered an alert. That's really, an epidemic and an outbreak that is really getting out of control. I just took this off the website this morning. I think, as you can see, it's the map colors as of 8/18. These are looked at every day, but I think, there is obviously a little variability, and I don't know how often they're going to update this map. If we go to the next slide, so this is also on the coronavirus WVGov website, and it really gives you the interpretation of considerations for each of these colors. And, I think I'm not going to certainly read this, but it really has mask requirements. I think, if you look at yellow, increased hand washing and hygiene, I think, that should be heightened at any level given the current circumstances. Student cohorting by limiting, exposure outside of core groups, which I think is really fundamental. And so, that's where we are. I think it is excellent that they've developed a system. Dr. Marsh talked a little bit yesterday about perhaps tweaking some of it, because if you have counties that have very, very small populations, then you get a couple cases, and then per 100,000 that is magnified. Now, sort of everybody, this epidemic is still new, but there is concern is that being overcalled. So I would expect some tweaks to this. We'll have to see how it works, but I think it's really an excellent, initial attempt to really sort of develop some structure about this epidemic in the state. These are the only 2 slides that I have relevant to the, sort of state alert system. It is new. I think we'll have to see how it goes, but I think I'll just pause there and take comments and questions from the group.
Hey, Sally, this is Allie. Can you hear me?
Yes, I can.
Oh, okay. Thanks so much. Knowing that this model has not been fully validated, as Clay has mentioned, that especially for rural states like West Virginia, what are your thoughts that if we were to go along with this model, what set of metrics would you want to see in order to validate its validity, its credibility?
Well, I want to say, first of all, that everybody is building the airplane in the air. If you look at the Harvard Global Health Institute, which has a similar system, green there is less than one, so there's some minor differences. I actually spoke at length with one of the individuals that's directing that, and that was based on expert opinion. It was not based on modeling, and obviously has not been validated. So the first point I want to make is, I don't think West Virginia is behind. I think that is, where we are in this epidemic. And I think really sort of starting and looking at something's very important. I mean, I wouldn't, I think we're going to have to look at the performance of this. Do a change in colors really result in a change in behavior? Because just remember, right now, the only thing we have to control this epidemic is human behavior. And that is, the usual stuff that everybody's talked about a million times: masks, social distancing, hand washing, hands away from your face, and so forth. I think that, the state has really followed very closely, and I participated in some of those discussions, looking very, very carefully at the numbers. This was a, very carefully taken decision. But I think we're going to have to look to see how it performs. And I think the other thing folks need to keep in mind is, right now we've been piping along. We've had some ups and downs and obviously outbreaks in parts of the state, not generalized. Certainly, I think West Virginia has really done much, much better than most other states in the union. However, I think when the weather gets cold and when I think influenza season comes, I think that is going to complicate it. And I think and I'm sure everybody's doing this for healthcare providers, it is just so critical that we really emphasize at this point the importance of influenza vaccine.
We also got a chat in from Dr. Rexroad saying the map for school sports will be the Saturday map, and the school alert map is to be updated daily according to what health officers are being told. So thank you for sharing that, Dr. Rexroad.
Yes, thank you. Other questions or comments? Well, we will certainly have to see how this performs. But again, I think it's really a great start, and it'll need to be tweaked. But I think it is certainly an important place to start. If hearing no other questions, then I think we'll proceed and talk a little bit about two of the chronic sequelae that have become apparent. If we could go to the next slide. Neurologic manifestations, there have been many of them associated with COVID. Encephalopathy, even in the initial sort of descriptions out of Wuhan, 7% of folks had encephalopathy, though more recently in France, it was higher than that. Encephalopathy can have a lot of different causes. If you look at encephalitis, which is an inflammation of the brain, and I'll show you some illustrations of that in a minute, there were 8 cases reported as of May. Since then, there have been more. Guillain-Barré, a demyelinating illness that has long time been associated with a variety of viral illnesses, not just COVID. There have been multiple case reports of Guillain-Barré. And then, stroke. There have been several series, and the incidence appears to range from about 2 to 6%, and that's among hospitalized patients. Most of the patients with stroke are over age 60, but there have been multiple reports of younger individuals, middle-aged individuals, and it's interesting. There appears to be a pattern that actually ischemic strokes with large vessel involvement are more common in the more younger patients. And there's an excellent review that I've referenced there in Lancet Neurology in July that really sort of summarizes the spectrum of neurologic manifestations with COVID. If we could have the next slide. So there are lots of possible mechanisms, and I think it's important to remember that many of these individuals become quite hypoxic. Certainly that will impact, brain involvement, and you can have, a hypoxic change in mental status. But, what I really wanted to talk about were several other mechanisms that are possible that folks have looked at. One is really direct viral invasion. As you know, a specific symptom of COVID infection is a loss of smell. And actually at the cribriform plate, that is the only place in the central nervous system that is not protected by dura. And it is a very sort of vulnerable area, and the virus is believed to directly invade the olfactory bulb, causing destruction and loss of smell. It's also thought, and that would actually is a direct extension into the CNS. Other possible viral invasion etiologies are really carriage across the blood-brain barrier. That cannot be through one of two mechanisms, direct viral invasion, or more likely what happens many times is going with a Trojan horse being carried in a lymphocyte or mononuclear cell into the CNS. It should be noted that there are ACE2 receptors present in brain vascular endothelium and smooth muscle. And in vitro, SARS-CoV-2 has really been observed to replicate in neuronal cells, and there have even been ACE2 receptors found in some glial cells and some neurons. So I think, really there is the predisposition for the CNS to obviously be involved. The other mechanism really is an immune-mediated mechanism, and autopsy material has demonstrated increased cytokines, monocytes, macrophages, and actually activated T cells that have infiltrated the CNS in individuals who have died. If we could go to the next slide, please. These are actually some scans that were taken from the Lancet paper, and I really showed those to really show the direct evidence of inflammation involving the brain encephalitis. As you can see in panel A, there is sort of a periventricular area there that lights up and is illustrative of inflammatory response in that part of the brain, as is the other section. Next slide, please. And then, going and talking about stroke, there's also been destabilization of carotid plaques. So people with antecedent cerebrovascular disease, you get an inflammatory process, it destabilizes those, and that's an etiology of stroke, as is the endothelial damage that really may result in activation of thrombotic pathways. And if we go to the next slide, these are a couple of scans that just show really large strokes in individuals who have had COVID, and it was felt to be COVID related. And I think, the strokes are interesting. I think there are a couple of varieties. If you really have set up an endovascular inflammatory process of vasculitis that really then activates this thrombotic pathway, that really is, a setting where stroke will be very likely. Of course, the others are that if you really have an inflammatory process that, causes a plaque to break away, and we'll talk about heart involvement in a minute, there have been arrhythmias, and certainly onset of AFib is there as well. And I'm really talking about not sort of the children who have had multi-organ inflammatory syndrome, but these have really been adult cases. Not that adults can't get that, and not that it might not be on the spectrum, but I think that it's not one mechanism that is really causing these manifestations. Next slide, please. I think more recently there has been more attention paid to psychiatric illnesses and behavior changes. Certainly individuals who are not infected with COVID but have suffered from social isolation and economic downturns. It's interesting that an online US survey of more than 1,000 folks, and this was early on, 36 reported that it was really having a serious impact on their mental health. And subsequently, online survey found psychological distress in 14%. And the parenthetical note there is that a similar survey a year before found that true only in 4%. And I don't think that's a surprise. But I think the other thing that has really come to the fore is really the neuropsychiatric sequelae to COVID infection. A month or so ago, there was a CDC survey in the MMWR that surveyed almost 300 folks with no chronic medical conditions. And now this survey was done at a median of 16 days after diagnosis. These folks, by and large, were outpatient. They had not been hospitalized. So this was, sort of what I would call mild infection. And 35% had reported that they had not returned to their usual health at the time of the interview, higher if you were above age 50. And the two symptoms that were least likely to have resolved at the time they did these phone surveys were cough and fatigue. There have been, I think, multiple anecdotal associations and precedent of previous viral illness. Perhaps the most well-known example is during the Great Influenza Pandemic, 1918-1919. Woodrow Wilson actually went to Paris to negotiate the terms of the armistice. He was being really sort of pushed by Clemenceau, who is the French leader, to bring Germany to their knees. France wanted the Alsace back. You all know the story. And the interesting thing about this is that Wilson was going to walk out. He absolutely said he will not do that. He got an influenza-like illness. He had high fever. He was confined to his bed, and subsequently after that was noted to actually have behavior changes, and they actually resumed the negotiations in his hotel bedroom. And the American delegation was shocked because he agreed to Clemenceau's requests. And if you read The Great Influenza, the assertion there is that actually influenza resulted in neuropsychiatric changes and may have actually laid the groundwork for World War II. Whether that's true or not, we don't know. But it was pretty clear that something went on, and it was probably influenza. As you've seen, there have been multiple anecdotal associations more recently. There have been, there's the well-known case of a relatively young New York physician who got COVID, recovered, had severe depression, and ultimately resulted in suicide. That individuals that knew this individual felt, was really clearly behavior change. So I think that the chronic sequelae are undescribed. I think there's been a lot about chronic fatigue. If we could go to the next slide. Before we get to myocarditis, there has been much written about chronic fatigue or a brain fog that has happened with other viral illnesses. But given sort of the pandemic nature and the millions and millions of people who are infected, I think that that perhaps, is the tip of the iceberg, and that, in future years, we're going to have to deal with that. And that's very difficult. How long it'll last, we don't know. The second sort of what's been called a long COVID, sequelae without known we don't know what's going to happen here, but that's the impact of myocarditis. And overall cardiac involvement in COVID-19 has been associated with a much higher mortality than if cardiac involvement is not there. Specifically to myocarditis, previous human coronaviruses have been linked to myocarditis really in all age groups. This is both the coronaviruses that can cause the common cold, but actually MERS, Middle Eastern Respiratory Syndrome, sort of earlier this decade, was associated with some myocarditis. Obviously, there were many, many, many fewer people involved, and so I think the natural history of that is unclear. The incidence of myocarditis in COVID-19 patients, we don't know. One autopsy series, and this was early on in China, found a 7% prevalence of myocarditis. But more recently, among 100 recovered COVID-19 patients, and these were individuals, this was a German series, these were individuals who did not have antecedent, cardiovascular or chronic disease. And these were individuals who had mild COVID. They were not hospitalized. So it wasn't somebody who'd been in an ICU for 2 months. Almost 3/4 had elevated troponins. And actually, this is amazing, 78%. They only had MRIs in 73 of the original hundreds, but 78% of the 73 had abnormal cardiac MRIs, and 60% had ongoing cardiac inflammation. And the thing that I thought was most remarkable about this series is when they looked at the MRIs, these were done roughly 2 months or more after the initial diagnosis. And if we go to the next page, or the next slide, this shows an endomyocardial biopsy of a relatively young individual. Again, no history of cardiac disease. And all the red dots there are dye that really look at activated lymphocytes. So there was a lymphocytic infiltration in this individual's endomyocardium. And on the right, you can see a cardiac MRI. The yellow arrows, fortunately, they put them in the paper. The yellow arrows really show pericardial inflammation and fluid, and the white areas show that there is inflammation of the actual heart muscle. And I think that this is my last slide. I think the question is will this result in a huge surge in individuals who go on to have heart failure? What are the implications for arrhythmia? I don't think we have absolutely any idea. And the other thing to keep in mind is that these were individuals who had relatively mild COVID symptoms. So I think that that's going to be another one where I don't know if we're just seeing sort of the tip of the iceberg, rear its head, but that is one that I think is we're going to have to stay tuned on. The story is not clear. I think I'll stop there, and folks can just comment, or we can have questions.
Thank you so much, Dr. Hodder. That was excellent. So before we did get a few questions in the chat, I just wanted to mention 2 folks who hopped onto the session who certainly need no introduction, but so we have Dr. Clay Marsh on as well, who's the Vice President, Executive Dean for the Health Sciences, and of course the czar. And we also have Dr. Lisa Costello from WVU Children's and DHHR Bureau for Public Health. So welcome to you both as well. I don't know if...
Maybe Mitra Clay would like to make some comments about the new state alert system and his thoughts about that.
I think you did a great job of describing it, Sally. The idea was to tethered this alert system to the system that has been championed at the Harvard Global Health Institute. And as Sally, who's been really a leader for us and the group in creating a lot of the parameters that we follow every day at the state, that we are really just trying to borrow from something that is popular among a lot of public health people, particularly around COVID. And as Sally said, this is a system that was designed by agreement of a bunch of people and not necessarily any dramatic, as I understand it, sort of scientific, statistical approach. And so as we apply this, which I think does make sense as we're color coding so that we are incentivizing communities to stay healthy, because ultimately the measure of whether we can open schools and keep schools open and open businesses and all that is really around the health of the community and how we regulate the spread of COVID-19 in communities. But in really small communities, and we've done some math that would say that two standards, so the average county in West Virginia is 23,000 people, and the two standard deviations away, the outliers are below 16,000 people. So we're now trying to figure out how we might tweak this a little bit, because eventually you'd like to see a total of at least 20 cases be the sort of the ground for making decisions. So you're not just making decisions on 2 or 3 cases that you multiply by a whole big number because you want to get to 100,000 population, which is the per capita level. So we're going to tweak it a little bit, most likely. But I like the system. I think it's one that is familiar to a lot of people that followed this at the expert level. As Sally said, Deborah Birx, who is one of the key people from the White House perspective, I know Sally knows well, was very taken with this color coding system. And in fact, she wants to share this with governors of the other states as a best practice. So I think it's a good model, but like any model, it needs to be tried and tested, and we have to see what we get, and we'll have to continue to iterate it. But Sally's an expert in many ways, much more than I am, and we appreciate her leadership during this time. And so I don't really, with all those words, I have no substantive additions to really make. So thank you.
Excellent. Thank you so much.
I'll just point out too that Lisa Costello has been doing a lot of great work at DHHR as well. So I don't know, Lisa, if you have any comments on the model, because I know you've spent a lot of time with Kathy Slimp when Kathy was the Commissioner of Health, and now looking at Ayn Amjad and still working with the EPI group and Amy and the others at DHHR.
Well, thanks, Clay, and thanks obviously for all that you're doing, and Dr. Hodder. I would just echo what, can you echo on Project Echo? What Dr. Marsh said. I think that, we just have to try this out, and, they're all models and we have to take into account. And I think, as Dr. Hodder has said in other echoes and other work that I've had with her, when you're talking about a rural population, it's a little bit more challenging because a lot of these models are made for more urban settings. So I think we need to be doing the research that the View is leading and others in our state to see how this impacts rural communities and how we use those models in some of our counties that are smaller, and our whole state is rural. But I think we're just going to have to see it in action, as Dr. Marsh or Clay said.
Can I make one more comment, which I think is really important? Sally talked a lot about these sort of new observations as far as some of the other organ systems that can be hit by COVID-19. And in the JAMA cardiology issue that had the study from Germany that talked about the evidence of myocarditis or heart involvement with COVID, there's also an article about direct infection of the heart, and perhaps, related, as Sally talked about, with the brain through the ACE2 receptors, et cetera. So I think that one of the issues that's becoming more acutely obvious, I think, to most people who are paying attention, is this is not just a disease that's, that you worry about dying, And that certainly is true if you're 80 years old or 70 years old, or even kids. Young people can die of this too, but not nearly as commonly as older people with comorbidities. I think what I am really starting to worry about personally, and I would presume, Sally, you'd agree with this, is the long-term chronic side effects of this disease. And I don't think, I envision that poster where you have the iceberg and you see the little bit above the water and you see this massive thing below the water. The above the water is what we know about COVID right now. The below the water is what there is to be known about COVID. And I'm worried that as we are starting to look at this, there's a CDC study or MMWR, monthly morbidity, mortality review or whatever, CDC publishes, that said that 3 weeks after COVID, 34% of outpatients said that they didn't feel up to their normal selves, and 20% of 18 to 35-year-olds said they didn't feel well enough to go back to work. So this is not just, get a little cold and you're fine. And some people, this is a big deal. And we're looking at, direct cardiac involvement, maybe direct neurological involvement. We know about the blood vessel involvement related to strokes and heart attacks and limb problems. And this is a multi-organ disease that has manifestations that we're just starting to recognize that can happen. And given the number of people that are getting infected, the real worry is the long-term complications of COVID-19. So I think what Sally presented here is super important to the people in the audience. And the other thing to know, and this to me I don't quite understand, but there is a small number of people that spread to a lot of other people. And then there's a lot of people that get infected with COVID-19 that don't spread to anybody else. And whether that's related to the amount of virus you have, the inability of the immune system to maintain it. But I think that really what we'll start to see is we're not only going to try to identify people who are infected with COVID-19, we're going to try to identify people that are infected with a lot of COVID-19, these super spreaders. And one of the things that I think is coming forward around the mask wearing is it may reduce the dose of COVID-19 that you're exposed to, both because you're blocking some of the droplets in the aerosol, but maybe the mask is protecting you a little bit from a huge dose. And that might be important as well in looking at the severity of things. So I think we're learning a lot about this. And Sally is an infectious disease person who's done work all over the world and is an expert. But I would love, Sally, for you to comment on that part of it, this sort of the evolving, emerging chronicity and sort of, some of the issues about dose dependency as far as severity of illness and all that.
Yeah, well, to take the second one first, so there is precedent with other viral illnesses that, sort of the frequency of infection is really related to the viral load. And of course, HIV that I've been in forever is really emblematic of that. And so if you have sex with somebody, and this is not respiratory, so it's different, but hang with me. If you have sex with somebody who has more than 1,000 copies per ml, you're much more likely to get infected than somebody who has less than 1,000 copies. And if you have less than 50, actually, there are enough large studies now that those people are not going to be infectious. Respiratory, I think, is a different issue, only by virtue of the fact that, having sex may be one thing, but just breathing, you just are in contact with a lot more people. And it would be hard for me to believe that wasn't operative, but that remains true. And they're really looking at that. I think that the other host factors, we talked, there's some literature to suggest that there's some gene polymorphisms, blood type that may relate to severity. I can't imagine that there aren't sort of host factors that relate to how easily you become infected that is probably important as well. I think going to the chronicity, and Clay brought up, and with the heart, it's very unclear if the damage is viral or if you get a little bit of virus in there and it is the immune response that causes damage, or if it is sort of, again, as we see with sort of the other vessels, and certainly the brain, it's a vasculitis that really results in some of the damage. And I don't think that that's completely clear. The German paper would like to suggest that it really looked like, it was inflammatory, a post-inflammatory response, but you don't know what headed off, and it might have been direct invasion that caused, the impetus for the immune system to respond. But here's the problem. How do you prevent that? Do you give steroids? Do you try to cut the immune response? Is that going to make it worse if it's direct invasion, or is it going to make it better if it really is immunodominant? And there are studies being constructed, but we really don't know. And I think that is going to be among the sort of most important sort of future focus about how to prevent some of these things.
Thank you so much to all of you. I don't know, Dr. Hodder, would you like some of the questions now related to your didactic?
Well, sure, and I'll invite all my other experts on here to answer them too if I can.
Absolutely, sounds good to me. So one of the first questions we got was, are the strokes related to the coagulation issues that are being seen in many patients?
Well, the answer is yes. I mean, there have been clear, the coagulopathy can really cause, thrombi, and that has been associated with it. There have even actually been hemorrhagic strokes as well. But I think the problem here, and this virus is a nasty virus. It doesn't do one thing. I mean, it has multiple areas to suggest it's this or this or this. I think it's highly probable that it's going to be various combinations and various importance in different individuals.
Thank you. Any other thoughts, Dr. Marsh, Dr. Costello?
I would just say, and I'm almost going to repeat what Sally had said earlier, we know coagulation is a big problem with this virus, and we know blood vessels are a problem with this virus too, because the ACE2 receptor is everywhere. So therefore, but I think what's really interesting is that we are learning about this virus all the time. So I think that the key for all of us, and particularly for the clinicians out there, is not to get too set on reading some literature today and going, okay, here's how everything works. Because I will tell you, in a couple of weeks from now, you're going to have a whole bunch of new data. And this is like, to me, watching, who was the war? Was it Iraq, or what was the war we saw real time where the guys were sitting in the hotel room going, oh my God, the bombs are going off outside the window. And, we are seeing this disease unfold real time. I mean, we're not seeing the sort of the sanitized version of everything. We're getting downloads of information almost constantly, some of which turns out to be absolute noise and will have no impact, and some of which is really important. But because of the volume and the rapidity and almost the real-time nature of things, we struggle as clinicians to get a handle on what we should do. And the truth is, this science is coming out almost unfiltered. And when you have science like that coming out unfiltered, it becomes really, really confusing. So I think that as we go, this is one of the reasons why having these kind of opportunities to talk to each other is so important, because it's not, I mean, Sally is a great expert at infectious disease and many other things. No, you are, but you also are learning about this real time, and I'm learning about this real time, and so are other quote unquote experts, Lisa and others. So ultimately, it's really about continuing this dialogue, not just during these Project Echo calls, but really almost continuously, so we can update each other about what we're doing, and maybe coming up with some sort of communication channel to be able to do that, because at some point, it's not just the data, it's taking that data and creating, actionable knowledge that we believe is the best that we can give right now that becomes really important.
You know, this really, I hate to relate everything to AIDS, but this very much reminds me of the early 80s and AIDS. And I will never forget, I had a patient, one of my early AIDS patients came and said, you know, my vision's changing. And he had cotton wool spots all over his retina. And I called the ophthalmologist guys and they said, oh, well, this looks viral. It's like, gee, thanks a lot. There were no antiretrovirals. I didn't write it up. And of course, a year later, there were the initial case presentations of CMV retinitis. And I just think that folks who are seeing, you know, clinically seeing patients and seeing these odd cases, I mean, you are the folks that really, I think, are you know, at the nexus to really describe some of the new things that aren't appreciated.
Absolutely, thank you. So the next question we have from Dr. Costello. So any thoughts on follow-up recommendations for patients of all ages, pediatrics and adults?
And I can qualify this more. Actually, I was a little late joining because I was talking to Dr. Amjad about, you know, as we learn more about this, what should be the routine follow-up? Some people are asymptomatic, you know, in pediatrics, for example, we don't typically get labs on children as routinely as we would say in adults. And I haven't really seen much. I think as the study Clay mentioned out of Germany and the long-term cardiovascular impacts, as well as Dr. Hodder, you know, that's more so what I was getting at, because I haven't seen much other than if, you know, in the original acute illness, you know, if you had acute kidney injury or, you know, acute hepatic injury or whatever, you would obviously follow those. But for those more asymptomatic individuals, in West Virginia, we just had our first diagnosed case of MISC in children today, you know, and it was multiple weeks after. And for that diagnosis, you know, it's just exposure to the virus in the past 4 weeks. So that's to qualify my question a little bit more.
Hey, Lisa?
Yeah.
Sorry to interrupt. Just tell everybody what MISC is for those of you who are not good with abbreviations.
With acronyms, yes. So multi-system inflammatory syndrome in children. It's a Kawasaki-like disease that we're seeing associated in COVID. It's not exactly Kawasaki, but it was described a lot in Europe. And then we saw a lot of cases in New York. It is rare. There's only been about 1,000 cases. Dr. Moffitt spoke to it briefly, but that's what MISC is. It's kind of an associated inflammatory severe reaction in the pediatric population. But thanks, Clay. That's good to clarify the acronyms.
Well, I mean, and I would ask others who see patients to comment. I honestly, I think that your question is a very good one, and I think the honest answer is we don't know what the optimal follow-up is and what it should be. I think the harder we look, you know, like the paper from Germany, when you look for myocarditis, and then once you find it, I mean, of course, you're going to have to follow those individuals, you know, much more intensely than you otherwise would. I think to what extent we should be looking for this stuff is not clear. So I think those are all the outstanding research and really urgent research questions that we need to find. And I would open it up to clinical colleagues as well about their thoughts.
Not everybody at once.
But I mean, that just speaks volumes. I mean, we're really, it's not clear.
I would also just say, if I could drop in for a second, that we're talking about specialty clinics for people that have had these organ manifestations of COVID. So whether it's heart or neurological, and it really also starts to bring in the question about what kind of baseline studies should be done on a population, because ultimately it's like, you know, the traumatic encephalopathy sort of concussion world, where you want baseline neuro psychological testing so that you can then detect subtle differences. So as we look at higher risk populations, and these days being younger seems to be a higher risk population, because 20 to 30-year-olds and 30 to 40-year-olds are driving a lot of this increase in COVID-19 caseload. And in the last 2 weeks of July across the United States, 97,000 children got infected with COVID-19. And in July, the month, I think we doubled the number of children that were infected with COVID-19 in the United States. So ultimately, and my understanding is if you're a kid and you're admitted to the hospital, your risk of going to the ICU is like an adult admitted to the hospital. So it's not, so if you're severely sick enough to be in the hospital, you're acting like an adult more than you're acting like a protected younger person. So this thing is just unfolding right now. And I think that it's not only for the general population who gets COVID-19, but I think as we look closer, as Sally, as you said, we're going to see more and more subtle manifestations of COVID-19, I believe, that will then dictate the types of follow-up clinics, particularly around specialty areas and academic centers like ours are, to be able to both understand and dictate better, treatments and outcomes in the future, but also just to learn more about this.
Mm. Well, you all make me feel better that still, I think it's just an ongoing question that, we have to determine, and I think it's going to be very important for what Dr. Hodder said of when you're seeing it on the ground, we need to be having these discussions so that we can see, what we're doing and what we're seeing, whether it's specific to West Virginia or what we're hearing from colleagues.
Thank you. So the next question we got in was, what do you attribute the transmission power of the newer mutation D164G of SARS-CoV-2 as compared to the Wuhan strain?
Others are free to answer this. It just appears to be able to bind more avidly to the receptor. Now, there's a lot of controversy about that. And I think that, it remains to be seen. I think we should remember, though, it does not appear to be more pathogenic. That is, it does not cause more severe illness than the previous one. It is, just been associated with an increased rate of infection, that it's easier to get infected. I suspect as we know more about this virus and how it works, as I said, as Clay said, anything we say today may be null and void in 2 months, but that's the current theory.
Yeah, and the only thing I would just add maybe to it is I talked to a friend of Sally's about maybe 2 or 3 weeks ago, Michael Osterholm, and I talked to him about this mutation, and he was just saying the same thing that you did, Sally, that people don't know the significance. It does appear to bind the receptor better. It doesn't seem to cause worse disease. In monkeys and primates, it doesn't seem to work exactly the same as it may be predicted in human models. So he's unclear about the sort of the impact of this, for what it's worth.
Yeah, I would say the same, that's exactly the limit of our knowledge at this point, and whether binding a little bit better has any pathogenic significance is really not clear.
Thank you all. So the next question we got in was, does anyone know if patients who are taking ACE inhibitors are at increased risk of more severe COVID-19 symptoms?
That is a great question. And everybody, there have been a couple good series about this. And by the way, sort of the ACE inhibitor, it's interesting, folks that are on those actually have a downregulation of their receptors. And there was an outstanding, and we can provide it, review of this, I think it was 2 months ago in the New England Journal. So there was a question, are they going to get infected more easily, have more severe, or less severe? And actually there have been several series, and Judith and Clay and Lisa should comment as well, that I think have been well done and have not shown that there's either an increased severity or a decreased severity, which is very reassuring. When this broke, I remember sort of reading commentary about taking your patients off of ACE inhibitors, but that does not appear to be important to do, and it doesn't appear to be different. I don't know, Judith, you want to comment?
No, I think you're exactly right. There's no there's no data that bears out that this is deleterious or useful. And if people's blood pressure is well controlled, I wouldn't mess with it.
I mean, the issue of blood pressure, going back to some of the complications we talked about, has been, folks have talked about that, it is very important for these folks to have blood pressure control. And there have been, some literature about the fact that actually very labile hypertension folks come in on antihypertensives. As you know, hypertension in some series has been associated with more severe disease and certainly worsened outcomes. And some folks, and I think that this is theoretic, I don't think it's proven, but some folks suggest that it's really because the blood pressure is very labile, you have CNS manifestations that may be made worse by a high blood pressure. So I think, important thing is control the blood pressure.
Excellent. Any other thoughts before we move to the next question? All right, excellent. So the next question is, do you think SARS-CoV-2 could potentially accelerate cognition decline leading to AD?
Who knows? I mean, I think, this is the problem with the new virus. Personally, I don't think we have any idea. I wouldn't even want to render a guess. I don't know, maybe others do.
Let's just say better not to get it to find out.
Right. Well, to that point, it's pretty interesting because what these emergence of the long-time complications, I have some kids that are, not that young, but 30s. And, before it was, well, like, who cares? We should just get over with it. They live in Metro New York. I'm not so sure that they actually had it at the time. And now it's sort of a different ballpark for those kids. And it's and I think that it's important to really educate patients. This isn't just about getting a bit of a cold and getting over it in a week or two. It really is got implications that we don't know. And at least, sort of some of the folks that I know in that age group, I think they have become much more careful, understanding that what the possibilities are here.
Thank you. So the next question we got in was, I believe, related to the didactic, Dr. Hodder. So the study that showed abnormal cardiac MRI results, were those patients symptomatic with cardiac symptoms? What were their symptoms?
So this was the German study, and these were individuals who had by and large had mild COVID. Some of them did have symptoms such as chest pain, which can also be related to respiratory involvement, but these were not individuals who were hospitalized, and they were really surveying and looking at the troponins, and when they found such a high percentage had elevated troponins, that really sort of prompted them to go look for the myocarditis. I don't recall, to be honest, I'm not going to say no had any symptoms, because I don't know that to be true. But the thrust of the article is these were folks who didn't have severe illness that you might not have expected. And then when you went and did the cardiac MRI, which, is not sort of a routine sort of thing we would do, they found a high prevalence of involvement. And
Maybe, Sally, I'm sorry.
No. I was just going to say the other thing, when they compared, sort of to healthy folks, they were more likely individuals who had COVID, because initially in this study, they also had a cohort who were uninfected, and they compared the troponins. They actually, when you looked at just LV function, it was a bit lower in those that had COVID versus not when they were adjusted for age. I'm sorry, Clay.
No, I was just going to say that as I remember that study, they weren't really clear about the symptoms, but 2/3 of those people were outpatients, 1/3 inpatients, average age 49, average 71 days post. and no real association statistically with duration, severity, or pre-existing comorbidity. So it really argues that it's, to me, that was 71 days. That was like 2.5 months after you had COVID, and 2/3 of these people were outpatients. So it's concerning, to me. That's that sort of top of the iceberg, bottom of the iceberg, because and I think that there's evolving and emerging data. The Big 12 or the Big 10 and the Pac-12 both canceled their football seasons, and at least I know 2 kids in the Big 12 had active myocarditis related to COVID, which was one of the things they're really worried about. So the heart involvement is really causing sports medicine people to be very concerned, because if you look at sudden death in healthy athletes, I think about 10% of that across the board is myocarditis. When you and now you have a cause that German studies said that 80% of people had abnormalities and 60% of people had active myocarditis. And the other article said that COVID may be able to directly infect the heart. So that is very concerning to me.
Well, let me ask, just put Clay on the spot. So we're going to have the breakthrough, right? This isn't forever. I mean, we're going to have, I think, a vaccine, God knows when, but probably maybe a year, maybe sooner. Given what we're finding out about the risks, something that has been unclear to me is why, sort of decision makers feel this is business as usual, as relates to athletics specifically. I mean, what do you think that is a wise decision?
Do I personally think it's a wise decision?
No,
or
I mean, what's your professional opinion? I mean,
Okay.
I'm appalled by this, but you know me, I'm outspoken.
No, I love you. So here's what I would say. I would say really 2 things. So number one is, and you guys know this from a clinical standpoint, if you're a Jehovah's Witness and you come into the emergency room and you're bleeding to death, and we say to you, you will die without a blood transfusion, it is your right to not take a blood transfusion. And it is ethically correct. I think at this point, we would do everything we could to save you, but we would not give you blood. If that was your wish and you were a Jehovah's Witness and we believed you understood the ramifications. So I think that, to me, I'm rolling back in some ways to ethics, to biomedical ethics. And I think that the 4 issues that to me are the keys are autonomy. Everybody has the right to make decisions about themselves in their own life. Beneficence, we try to do things for the greater good. Justice, we try to treat everybody equally and transparently. And then informed consent, that we need to share life-threatening complications and common complications of things that we might do to people, including prescribing drugs or surgeries or whatever. So on this one, I have to say, on a personal level, on a parental level, I feel very concerned about all of sports and, these activities that collide people together. That makes me nervous. But from a professional perspective, I believe, like I would about anything else, that as long as we are giving people the information that they need to make an informed choice, and to me, that's parents for underage children, or, if you're of adult age, to give you the risk and the benefits, including life-threatening risk and common risk, and you make your decision, then, to me, that is your right to do. Just like, we would say, wow, if people are playing football, they could get COVID, look what COVID could do. But I could say, look at the motorcycle sort of adventure into the South Dakota town where 200,000 people entered this town and went to a big concert and nobody's wearing a mask, or if you look at the colleges, they're having problems now. So I think that there's an explicit belief that we can control COVID, or if we can't, we need to disband certain things. We can't control COVID anywhere. And that's the whole point to me about just trying to do the best we can. And so, when you look at colleges coming back in, we know UNC Chapel Hill, a week and out. University of Notre Dame, a week and out. Michigan State, out. And I think more colleges that were planning to be in person are now going online because they're kind of going like, well, we can't do this. And in Georgia, the school system in one of the counties, a weekend, 1,000 people quarantined. Israel tried to do this and got a hot summer week, and everybody was complaining about wearing masks and leaving windows open was inhumane. So the government gave the kids 4 days off of wearing masks and closed the windows to let the air conditioning work. And 242 schools had to shut down. 1,000 people got COVID, and thousands of people were quarantined because that 4-day period. You know, I would say that the problem that I have is that there is a lot of other issues wrapped up in college sports and professional sports and money and power and, you know, so there's that backdrop, and then there's the political issues. But I'm really drawn to one single thing, and I'll shut up after this, because the truth is I don't know the right answer, and I think that people should make the decisions as long as they have the right information. But there was something that happened really, really early in COVID that made the biggest impact on me that I believe supersedes almost all the other things that we're talking about. And that was a little mathematical agent-based model that was published in the Washington Post. And basically there's 4 scenarios, and agent-based models are where you basically define each element in the model as an agent, as an individual, and you give it certain rules, and you let all these collide with certain different parameters, and you see what happens to the population. And this was about physical distancing and the spread of COVID, but they have 4 scenarios. Number 1, you do nothing. Number 2, you order and create laws around it. Number 3, you get everybody to agree at about a 75% level. Or number 4, you get everybody to agree at about a 90% level. But the one that really struck me was the laws, policies, quarantine. You made people do it from a hierarchy standpoint. So the first model failed. You know, that's what Sweden has seen, that, you know, even if you try to get people to separate, if they don't do it, it's not going to work very well. Second model, though, was equally as poor. It just took longer to kind of get to the surging, because then you pitted the authorities versus the people, and people escaped the model. The ones that worked the best were the collaboration at 75 and 90% agreement, 90% being really good. But I think the key, and this is what I think the governor has done well in West Virginia, and what all of us as a populace has done, we've stayed together. We haven't been marching on each other. You haven't seen people with their guns on the Capitol steps to, you know, open the schools, open the businesses, you know, and these fights where we fracture, which the whole country is doing, those are the things that I think actually kill your outcomes. I think that as long as we stay together and we try to look out for the best intents of the health and the well-being of people, and you can pull out an equal number of articles that say that social isolation and distancing is causing depression, overdose, suicide at much higher rates today than coming back together in schools and the risk of COVID. But I think as long as people understand the risks and the benefits, and we do it together, I think that's probably the best we can do right now. So anyway, sorry, Sal, that was a non-answer to your question.
But it was entertaining.
Thank you so much. That was very entertaining and valuable input for sure. Unfortunately, I always wish these sessions were a little longer. We have come to the end of our session time. Dr. Costello added a link into the chat for the return to work guidance from the CDC. So as usual, I'll attach any resources into the recap email along with Dr. Hodder's didactic. Just a quick housekeeping announcement. So our next session will be on September 3rd. I can't believe I'm already saying September. And at the end of that session, we're just going to do a quick poll just to gauge some of the feedback on our COVID echo session. So if you all could stay on a few minutes after for the next session, that would be excellent. And finally, I just want to thank Dr. Hodder for the excellent didactic. I also want to thank Drs. Marsh, Costello, and Feinberg for the super valuable input and helping to answer any questions. So thank you all so much for joining. We'll see you guys next time.